Welcome to ISNTD Connect. For those of you who are new to the series, my name is Maryann Delea, and I'm speaking from the International Society for Neglected Tropical Diseases. A very warm welcome to you all, and for the many familiar faces that I'm already seeing saying hello over on the chat, again, welcome back. And it's a real pleasure to have you all tune in today. So thank you very much for that. Today's session promises to be really fascinating. Today we're going to be talking about hand washing, such a simple, on the one hand, such a simple intervention, and on the other one with such magnitude in terms of disease control and disease prevention, but also for healthcare professionals. And also, of course, touching on things such as behavior change, community engagement. So a really fascinating topic all around. And what better time than in the midst of the COVID-19 pandemic to kind of take stock of some of the latest thinking and tools in hand washing, and also have a great discussion around this, not only in terms of the pandemic, but also more generally, hand washing's role in neglected tropical disease control and also just in health in general. And I'm so pleased today to welcome our wonderful panel. It's a real pleasure to welcome today our three speakers. We're joined today by Professor Miryam Wahrman. Hello, Miryam.
Hello. Very good to be here. How are you?
You're well, all good, thank you. You're well as well?
Yes, thank goodness, yes.
Professor Wahrman's tuning in from New Jersey and is Professor of Biology at the Paterson University. And Miryam, you're also the author of a book called The Handbook, Surviving in a Germ-Filled World. So we'll be hearing more about that from you in a few moments, the history of hand washing and also how this has evolved all the way up to now amidst this COVID pandemic. Following from that, we are going to hear from Dr. Maryann Delea. Hello, Maryann.
Hi, Maryann.
Hi. Thank you so much for joining us. Maryann, you've just recently, you are a co-author on a recently published paper in which you have been looking at a quantitative tool to assess personal hygiene. So we talk a lot about hand washing, but also face washing in terms of public health, and actually putting that into a quantitative measure is not the easiest thing. So we're really looking forward to hearing a little bit more about how you and your team went about to developing a tool.
Fantastic. Thank you for having me.
Yeah, great. And although your name is neither Miryam or Maryann, we still have included you, Lizette. Hello, Lizette Burgers. You are Senior WASH Advisor at UNICEF, and you're going to talk to us, give us a little bit of insight from the field and talk to us a little bit more about hand washing and COVID, and beyond that, some lessons learned for, in general, hand washing in public health interventions. So we have a fantastic panel. Without any further ado, I notice my audio and video is a little bit pixelated today, so I do apologize for that. I hope it's coming out clearly on everyone's side. So for now, I'll hand over to Miryam.
I wrote a book about 4 years ago, and I gave it the title, The Handbook, Surviving in a Germ-Filled World. But first I want to say that I am honored to be here with this group of very accomplished professionals, and I am really pleased to meet some individuals who have really contributed to the field, a field that I've been thinking about for years now. When I wrote this book, and I gave it the title, The Handbook, Surviving in a Germ-Filled World, I had a hypothetical vision and thought that this was going to happen perhaps in my lifetime, and then here we are. And the interesting thing about this experience is that 4 years ago, the people who were interested in it were already people practicing in the field and were convinced that this is a thing, that hand hygiene really is important. However, the vast majority of the public was kind of neutral or disinterested, and all of a sudden, everybody is on board with hand washing. So that's something that I find to be really a revelation with regard to what's going on today. So this, thank you, Maryann, for putting together this wonderful session, because it is a compelling issue, and the issue of hand hygiene will stay important, in fact, critical, even when we are beyond the current crisis worldwide. So the message is very, very important. And the message is so important about hand washing that there are 2 dedicated days every year for the cause of hand hygiene. And one is coming up next week. It's the World Health Organization's World Hand Hygiene Day on May 5th of every year. And the other one in October is the Global Hand Washing Day, sponsored by the Global Public-Private Partnership for Hand Washing. So that shows you how important it is in the minds and hearts of anyone who cares about public health. Now, of course, I want to greet the audience from around the globe, all of whom appreciate these issues, but I'll just mention that we are concerned now in particular, but always, about germ-laden surfaces in public places. And this is just a list of some of the things that we touch all the time and don't give much thought to. However, when we're in the midst of a corona pandemic, it all of a sudden becomes so important that you went outside and you touched something, and now you'd better sanitize your hands. And in healthcare settings, it becomes even more important because, you know, we're talking about life and death in an immediate way. And these are just some of the numbers associated with the tragedies that can occur if hand hygiene is ignored or if it is marginalized. So, for instance, we have the figure of 5 to 10% of hospitalized patients who contract hospital-acquired infections. And that includes, very sadly, my mother, who passed away 20 years ago in a hospital, very fine New York hospital, but she passed away from a hospital-acquired infection, even though she went in for cardiovascular disease. So this is a very personal issue for me, in addition to the professional importance of it. And it highlighted the fact that some healthcare workers did not wash their hands properly, and some are still learning. And now, of course, we see our healthcare workers and public health professionals on the front lines are doing everything they can to do everything right to reduce the risk. And that is something that is gratifying, and that message is registering. Let's go back in history, because the idea of hand hygiene, although it seems like the science and the scientific approach has been very recent, the science goes back a couple of hundred years, but the idea of hands being impure or soiled, that goes back thousands of years. And so we can look at religious hand washing rituals that have been discussed and written about for thousands of years in Islamic and Jewish and Christian and Hindu sources. And those individuals from those groups and for people of other faiths have used hand washing as part of religious rituals. So, for instance, 3,400 years ago in the Hebrew Bible, the Old Testament, the Israelites made a basin for washing. And the citation in the book of Exodus says, "They shall wash with water that they die not." Okay, now that's a statement about hand washing that goes back thousands of years. Now, of course, we're talking about ritual washing, using a cup to pour water over one hand and the other hand. Turns out that recent studies show that ritual hand washing, just rinsing with clean water, does significantly reduce the risk of germs. So there was something already there back then, thousands of years ago. let's fast forward to ancient Greece and Rome, and then to the Middle Ages. The word hygiene is Greek. It was the goddess of health and cleanliness, and in the Greek culture, hygiene was very important. They established public water supplies, and fountains and bathhouses were important within that culture. Even though they did emphasize cleanliness, there were plagues, and the plague of Athens decimated the population in the year 430, 430 BCE, before the Common Era. Following the Greeks, the Romans also emphasized health and hygiene, and yet they were decimated by a plague that killed a third to half of the population, the Antonine Plague. And then we have hundreds of years, centuries of time when people more or less ignored hygiene and hand washing. And this culminated in the Black Death in the 14th century that killed almost half the population. And included much of Europe and Asia and North Africa. So these were, of course, terrible tragedies, part of our history and the history of public health, from which we can learn some lessons. And then we turn to just several hundred years ago, the era of what people have called microbe hunters. One of the very first, Anton von Leeuwenhoek, developed a microscope that was able to reveal the microscopic world of microbes, including pathogens, which are the disease-causing agents. And he's quoted as saying, upon observing the microscopic world, "Come here, hurry, there are little animals in this rainwater. They swim, they play around," and so on. So this is, of course, a great advance in science, to be able to discover the microscopic world. Continuing with the microbe hunters, we have the person who I have called the father of hand washing, Ignaz Semmelweis, who lived in the 19th century. And he did indeed discover and document for the very first time the relationship between hand washing and the reduction in infectious disease in a hospital setting. He worked in the Vienna General Hospital, and he observed that doctors who staffed the maternity ward had maternal deaths from childbed fever, puerperal fever, that were significantly higher than the clinic where midwives were delivering babies. That he discovered that the doctors would work in the morgue dissecting corpses and then run to the maternity ward to deliver a baby without washing hands in between. At one point, one of his friends, a doctor in the clinic, accidentally cut his hand with a scalpel. He contracted that disease and he died. And this certainly was a wake-up call. And Semmelweis hypothesized that cadaverous particles, because they weren't known yet as specific microbes, from the morgue were killing the mothers. So he was able to arrange the hand washing for doctors between the morgue and going to the women to deliver babies. He tested his theory. They required doctors and medical students to wash their hands and the instruments in a solution of chlorinated lime. The mortality rate for the new mothers dropped from about 18% to about 1%, which is a tremendous success and saved a lot of lives. Despite his success, it's very hard to change prevailing views, and his idea was met with great resistance. They actually terminated his contract. He returned to his roots in Hungary, to a small hospital, where he implemented the same changes and saved lots of mothers' lives. But he had, it is said that he had a breakdown, a nervous breakdown, and he died in a psychiatric institution, a broken man at a very young age of about 47. So that was a tragic story of really a healthcare hero, and that's something that we can learn from. Here are some other microbe hunters that I will mention because of their tremendous contributions to the field of public health. Florence Nightingale, probably the mother of nursing, improved hygiene in military hospitals during the Crimean War in the mid-19th century. And her ideas about hygiene helped not only in healthcare settings, but also in terms of household cleanliness. And she influenced many people to implement better hygiene practices. We go to Louis Pasteur, who is probably one of the most important scientists contributing to healthcare. In the mid-19th century, not only did he raise awareness of germs and pathogens, but he also devised various types of protocols to reduce the risk of pathogenic microbes. For instance, heating up milk to decrease the amount of microbes in milk. Now we call that pasteurization. So every carton and bottle of milk that we have has his name on it because it says pasteurized. And he changed our understanding of many areas of biology and medicine, infectious disease, and health and hygiene and immunology. And his work helped us to address diseases such as rabies and other infectious diseases. But he also worked in the alcoholic fermentation industry, the silk industry, and developed ways for us to deliver our products aseptically, aseptic packaging. So, of course, he made tremendous contributions. And following his lead, Robert Koch was the scientist who discovered the anthrax bacillus and launched a research field where we could link a particular pathogen to a particular disease. And so once you establish cause and effect, then, of course, you need to devise ways to eradicate the disease, to target those pathogens. And he worked on cholera, tuberculosis, diphtheria, typhoid. Those were areas where scientists used his methodologies of linking the pathogen to the disease, a tremendous breakthrough. One other scientist I'll mention is Joseph Lister, who pioneered antiseptic surgery. And just a couple of decades after his work was published, there was a company that produced an antimicrobial product and named it after him. That's Listerine. But of course, his work influenced the way all surgery is done, and as did the other scientists. And hand washing became a routine and required part of surgery. And now, of course, it's a routine and required part of all lives and everything that we do. You are all familiar with the different types of microbes, all of which have examples that can cause disease. And nowadays we're thinking mostly about the viruses, but of course, bacteria and fungi and protists are able to serve as scourges to populations in different parts of the world and in different populations. Now let's turn to the hands a little bit more, because hand microbiomes, that is how we describe all of the microorganisms on our hands. And the term microbiome has become very important in the past decade or so, because microbiologists are interested in cataloging all of the pathogens. And if we can learn about all the different species that live in a particular area, then we can target those that are making us sick. We can target the pathogens and try to preserve the ones that are not dangerous to us. So the human skin microbiome harbors more than 1,000 species, and some of them are benign, like staph epidermidis, but some of them cause very severe diseases and deadly diseases, like Staphylococcus aureus and Streptococcus pyogenes, as you can see from this slide. If you send your child out to play in the backyard, bring them in and have them put their hand on a petri dish, this is the picture that you get on the left. And it shows you that our hands are just filled with microbes, many of which are harmless, but some of which can make us sick. And hence, we're here talking about hand hygiene. And this little fella is one of my wonderful grandchildren's newborn hands. It was just irresistible to me because I was writing a book about hand hygiene. So who is washing hands? So what is this about hand hygiene that makes it so compelling? And the answer to that is that we can be empowered to do something to keep ourselves healthy. And that's, of course, hand washing. And there are many studies that I cite. I really reviewed much of the literature when I wrote my book, The Handbook, Surviving in a Germ-Filled World. So I read an awful lot of works from hundreds of years ago up until, present times. This study showed that if you ask people, do they wash their hands after using public bathrooms, 96% of them say, yes, of course I wash my hands. But if you observe them, you'll find out that there are many populations that don't really wash their hands. So for instance, when people were observed in the public washrooms in various airports, in the Toronto airport, 95% actually do wash their hands. So that's a good score. In the Miami airport in Florida, in the US, 81%. In Chicago's O'Hare airport, it was 73%. And New York, my hometown, the JFK airport, only 70% actually did what they said they're doing. So at that point in time, people were not aware or were in denial about the importance about hand washing. And a lot of people simply didn't wash their hands after using public restrooms. That sounds kind of appalling, and yes, it is. If you they did a study of college students who you think, well, they're intelligent, right? They're educated. After defecation, 84% of females wash their hands and 78% of males, which means that about 1 in 5 come out of the bathroom without having washed their hands. And after urination, it's 69% and 43%. I would imagine that after this experience of the COVID virus, people are much more hand aware and much more germ aware. So I believe that these numbers will be higher and better. And perhaps this effect, the corona effect, I would call it, may last. And as a lasting effect, it will help our public health in many, many ways for years to come. That's the hopeful part, the silver lining in the cloud. In our laboratory, we have been studying bacteria and the transfer of bacteria from one surface to another. We are so aware of this now as we go out into the germ-filled world and we don our masks and gloves to try to avoid catching the coronavirus. Because it's not just hands that transfer germs, the other surfaces, the fomites, carry and transfer germs as well. So my lab has been involved with looking at different types of surfaces. We focus on fabrics, on different clothing and so on, to see what types of fabrics carry and transmit germs. We've studied polyester and silk, cotton, wool, microfiber, and scrubs. And one particular material stood out as being something very interesting. It's a kind of microfiber that seems to repel bacteria. So in our experiment, the different fabrics transfer E. coli and other bacteria from one to the next, but the microfiber doesn't appear to transfer E. coli to another swatch of microfiber. And there's something special about this. It happens to be hydrophobic, but it also repels germs. And this is one experiment that I'll show you quickly, where we did from one swatch to another different kinds of materials. And in one case, we had no transfer of bacteria. The cloudy white material as E. coli colonies, and it does not transfer to another swatch. On the bottom, on the left, the white material did not transfer from one swatch to another. That's the microfiber. So those are important types of observations because we want to reduce the transfer of all types of germs, bacteria, and of course viruses. And this is one example of a research study that we did that should be helpful, hopefully, to reduce the transmission of germs. And microscopically, we looked at these fibers, and you can see clouds of bacteria surrounding silk and wool and polyester and scrubs, but microfiber on the bottom right appears very clear and actually repels the cells, the bacterial cells. So we were very excited about this. When looking at differential adherence of bacteria to microfiber and scrubs, scrubs is the the garment that the surgeons and healthcare workers are wearing. We find that microfiber has a much lower amount of bacteria compared with scrubs, and across the board, this was all statistically significant, except for one instance where it showed a trend but not statistical significance. So under various conditions, microfiber appears to repel the germs. And that's something that we are pursuing in greater detail. This shows you what it looks like in the electron microscope. So our conclusions regarding this particular research study is that the different kinds of bacteria adhere to many fabrics. That's something of concern if you're in a hospital setting. And nowadays, wherever you go, you're concerned about this. Microfiber stands out as having the lowest level of association with bacteria, and natural fibers appear to have the greatest affinity. So this is the kind of thing we're looking at in order to advise and make recommendations with regard to healthcare settings. And microfiber is less likely to transfer bacteria to other fabrics. We also studied various ways to decontaminate, like hydrogen peroxide, and those are some of the things that we are concerned with in our research lab. Another study that we conducted that I'll go through very quickly has to do with food handlers. And this publication in the Journal of Community Health discusses how various food handlers in food carts in New York City are not doing the things they're supposed to be doing with regard to hand hygiene. Now, it probably changed or will change in light of what we're going through now. However, these observations, which were just made a year or two ago, showed that the number of times that food vendors changed their gloves out of almost 500 exchanges, only 7 times. So our food handlers were not doing what they were supposed to be doing. I think that this very tragic pandemic is going to change some behavior. We shall see. But certainly it's something of concern. We did transactions with food vendors and collected change, right? Money, these are dollar bills that we collected, and then we cultured these dollar bills to see what grows on the money that's being touched by the food vendors who are touching our food. Okay, so there's a chain of transmission, touching money and then touching food and then giving you the food to eat. So what's doing with these dollar bills? And sure enough, most of the dollar bills are contaminated with a variety of different kinds of bacteria, which is what we were studying. And a good portion of them were coliform bacteria, which can be disease-causing. So this slide doesn't look as good as it did when I uploaded it, but these are the top 10 simple, empowering solutions for everyone. And we know a lot of this now that we are in the midst of this pandemic. Number one, don't shake hands. But what I would like to say is that when all of this is behind us, which one of these types of behaviors will stay with us and will help to keep us healthy and empower us to continue to do the right thing? Will we go back to shaking hands? Will we do the fist bump? If you do shake hands, my approach, my philosophy is to be germ aware. I go out in public and I do touch things, and I always have, even though I wrote the book on hand hygiene. But if you do go out and touch things, just be germ aware and make sure that you sanitize your hands either by good hand washing with soap and water or with a alcohol-based hand rub. So keep your wash areas stocked with soap and clean cloth towels or paper towels, and keep your alcohol-based hand rub handy. And especially for caregivers, for children, or for adults who need their care, it's important to keep your charges' hands clean. And teaching your children about hand hygiene, we can't emphasize that enough. And if you are a supervisor at work, make sure you have facilities for your workers to cleanse their hands. Healthcare workers, it goes without saying, but I'm going to keep on saying it forever, that healthcare workers have to be vigilant about hand hygiene. Every patient should ask their healthcare worker, if they're stuck in bed, to have somebody help them wash their hands before they touch their face. Even if you're in bed and you're a patient, you should still be washing and cleansing your hands. If you're buying food in a food preparation facility, restaurant, or street vendor, be aware of who's touching your food and how they're touching it and whether they are washing hands. And let's keep track and learn about our local health codes and advocate for them so that we have strong legislation to protect us. These are some practical things that should remain with us after this crisis, after we've passed this crisis, because there will be other times in the future where we'll be grappling again with challenges, hopefully not as widespread. The book that I wrote, the handbook, Surviving in a Germ-Filled World, talks about the science, the medicine, the history, and the culture, solutions to these issues, and even handy lists of ways to lower your risk. And I do think that we can learn a lot about this. By the way, this is a portrayal of a subway or underground. This one is in Japan, and we hope that one day we can get back to public transportation with confidence that we can stay safe even in that type environment. I just appreciate the opportunity to speak within this group of experts who have been working on so many different areas of this. I'm very honored to be part of this group, and I look forward now to hearing from my esteemed colleagues who are going to continue and tell us some of the other aspects of hand hygiene that are absolutely critical in this time. And I will just to end by saying, please everyone, stay safe and stay well, and continue to transmit this message that we can be empowered. There are things, simple things we can do to keep us safer and healthier and reduce our risk. And again, thank you for inviting me. It's been a pleasure. These are some of my colleagues, my acknowledgements.
Well, Miryam, actually, it's us who thank you very, very much. Thank you so much for this very detailed historical account of hand washing, but also a complete 360 view on hand washing and on hygiene in general, and also, of course, great advice moving forward. I was really sad and touched to hear about your mother, Miryam, and I think was a great reminder that behind all of these statistics and figures that we hear, there are also, very individual stories. So it's always really important to remember that. And I think the message that we've all been hearing, wash your hands, save lives, stay home, save lives. These little interventions do have a real impact in the field and in terms of people's health. So thank you very much for bringing that home. We've had a lot of people. Thank you. We've had a lot of people thanking you for a great presentation, Miryam. Aruana Froze was saying thank you for the great presentation. Selvi Subramanian says also So thank you. It was a presentation. We've had Stephen Brahma, Zdzisław Iwanieszko, I hope I've pronounced that right, saying greetings from Poland, working in WASH innovation. Jeremy Mays is tuning in from Bolivia, from the SODIS Foundation. Toby Landeyu from a rainy London. I know, I hear you, I'm there too. And quite a few people as well working directly in WASH. We've got here Erin Palomares, hello, from the Global Handwashing Partnership in DC. David Rollinson, Natural History Museum, hello. Kelly Bridges from Global Water 2020 in Washington. I can't say hello to everybody, but you've got a really varied and international audience there. So hello and a big thank you.
I'm looking at this list. I appreciate the audience out there and their very intelligent comments and suggestions. And just want to say that the ebook is available if there's something that would be helpful to them. It's on Amazon.
Yes, I think it's important to point out that your book is totally out of stock in print in many bookshops, but still available as an ebook, and that is quite understandable given the current climate. Perhaps we won't have time to take all the questions right now. However, we had a great question here from John Gibb. Hello, John, who until recently was working with the Department for International Development, DFID, here in the UK, and was just asking kind of the $1,000,000 question, is that given the impact, as you've very well described it, of all these opinion of countries don't give hand washing and WASH generally a higher priority until, of course, something like COVID strikes and suddenly we're all washing our hands thousands of times.
Yes, so I have found that when my book came out also, it was very much welcomed by the community. It's like preaching to the choir, that's the expression. People who already understood the importance of hand washing welcomed it with open arms, so to speak. And others just said, oh, we know that, you know, we don't really have to think about that. But there are people who actually rejected it and said, that's not so important. You know, we have to have germs. And that's true too. We have to have our immune system stimulated by germs, but we do want to reduce the risk of being exposed to the pathogenic ones that can really kill people, you know, make us very sick and result in death. So this is a wake-up call, and all of a sudden people are saying, oh yeah, you know, hand washing, right? I remember my mother used to tell me to wash my hands. Now I see why it's important. And I guess that's the silver lining in a very, very dark cloud, that we are raising awareness of the things, simple things to empower you to reduce your risk. And you're right, that it should be much more done on a much more official level, on national levels, on international level. Some of our public health organizations do a wonderful job in promoting it, but they're not so widely disseminated. So let's, turn to our what's the day, May 5th, the World Hand Hygiene Day, the World Health Organization, and turn that into something big that we're talking about, hand hygiene.
Excellent. I think that's elicited more questions and more comments, and perhaps we will return to those after we've heard from our other speakers. But for the time being, I think we'll move on for now to our next speaker, Dr. Maryann Delea. Maryann is an epidemiologist at the Carter Center, and as I said earlier on in the call, is one of the co-authors of the recently published article looking at researching the development and the reliability of a quantitative personal hygiene assessment tool. So this was published recently in the International Journal of Hygiene and Environmental Health, and we'll circulate a copy of the article in a few moments. But Maryann's here today. We've heard a lot about sort of the history and the importance of hand washing in hygiene in so many different contexts. Maryann's actually worked on with her team on a tool to quantify what do we mean when we talk about face cleanliness and hand cleanliness. So I'll hand over to you, Maryann. I'll let you launch the presentation your side, if that's all right.
Okay, great. Thank you, Maryann. Are you able to see the slides now?
Everything's very clear. Thank you.
Perfect.
All right.
So we'll be shifting gears a little bit. And as Maryann indicated, today I'll be presenting on the development and reliability of a quantitative personal hygiene assessment tool, or QFAT as we called it, and implications for holistic WASH program evaluation. I think this goes without saying in a forum such as this, but personal hygiene practices, including face washing and hand washing, are important for preventing exposure to and transmission of various infectious diseases. But the issue here is that they're often very difficult to measure. Many cleanliness measures actually reflect proxy indicators of personal hygiene behavior. Conventional qualitative metrics tend to yield binary outcomes that may lack the nuance necessary for actually distinguishing between various levels of cleanliness. And because behavior change is often incremental, we should really be striving for metrics that are sensitive to incremental change so we can actually monitor and evaluate that change over time. And while it's important to develop reliable metrics, it's also important to note that reliability does not equate to validity or utility. Cleanliness metrics should generate valid measures of cleanliness and also predict recent cleansing practices. So that's something important to consider as we move on in the presentation. Okay. Work I'll be presenting today reflects a sub-study that was embedded within a larger cluster randomized trial called the Delea trial. The purpose of the Delea trial was to evaluate the impact of a demand-side sanitation and hygiene intervention on sustained behavior change and mental well-being. This was conducted in Amhara, Ethiopia. And as a result, because that was our purpose of the study, we were particularly interested in ensuring high-quality measures of the uptake of improved sanitation and hygiene practices. And we wanted to potentially improve upon existing metrics used to assess facial and hand cleanliness. The trial was conducted in 50 randomly selected sub-districts in 3 districts within West Gojam and South Gondar in the Amhara region of Ethiopia. And we randomly selected approximately 30 households with at least one child aged 1 to 9 years per study cluster. And this child was indicated as the index child. To enable better assessment of personal hygiene practices and enhance evaluations of personal hygiene interventions, we sought to create a metric that generates quantitative data on facial and hand cleanliness. The aim of this study was to develop and pilot a novel quantitative metric to assess the reliability of that metric and to also compare the reliability estimates and measurement attributes of the conventional qualitative facial and hand cleanliness metrics against this novel metric. And we specifically sought to examine whether the novel metric was reliable for measuring facial and hand cleanliness, and to determine whether the reliability estimates differed meaningfully across different types of readers, including those who were not blinded to the conditions of the household and the child, so the people who were actually collecting the data, as well as people who were blinded to those conditions, because we thought that there might be a bit of bias introduced as people were actually seeing the conditions of the household and seeing the conditions of the child when they were assessing the cleanliness of that child. And we were also interested in understanding how human generated rating scores compared to computer simulated rating scores. In order to investigate our research questions, we needed to develop a metric that would allow for quantitative assessments of facial and hand cleanliness. So we used color theory principles to create a novel standardized color scale to do that. And this scale depicted a continuum of color along the RGB, or red, green, blue color model array. And this ranged from 10 being the lightest color along the continuum to 0 being the darkest color along the continuum. And each point along the continuum represented a 10% increase in the saturation of the color along that RGB color model array. This yielded an 11-point QFAT color scale that we used. And after conducting some formative research to test and refine the color scale to basically understand what color model array we needed to define, we used the QFAT methodology to obtain quantitative proxy measures of personal hygiene through facial and hand cleanliness assessments. In addition to using this color scale, we also used sterile gauze pads that were pre-moistened with saline solution to collect wipes of hands and faces. We also developed and tested a standardized process for collecting those wipes of the face, so the area around the eyes, and the hands of one index child aged 1 to 9 years per household. And then raters were trained to use a standardized process to rate those wipes against the QFAT color scale. So they collected the wipe from the child's faces and hands by tracing the face and hands. And then about an hour later, so at the end of a household survey they were conducting, they scanned the wipe for the darkest square half inch of the wipe. And then they scored that darkest area against the QFAT color scale to identify the most similar color within that scale. And I'll explain in a little bit more detail in subsequent slides, but we also used a similar method to identify and score the darkest area of the wipe against the QFAT color scale when we conducted our densitometric assessments, which was the computer simulated rating scores. Right. So we designed our study to examine inter-rater reliability of rating scores across not only different rating groups, but also different cleanliness measures. So enumerators collected data from one index child per study household, and they collected those data. They started out with obtaining conventional qualitative measures of facial cleanliness. And this was measured by the presence or absence of ocular discharge, wet and or dry nasal discharge, dirt and debris on face, and the number of fly face contacts during a 1-minute observation period. These are standard qualitative metrics that are used in the trachoma community for assessing facial cleanliness. And for hand cleanliness, we looked at the qualitative measures as measured by presence or absence of dirt under nails or on palms and or finger pads, with each hand assessed separately. And again, this is a typical qualitative hand cleanliness metric that might be used by some wash professionals. After collecting data using the conventional cleanliness metrics, enumerators also collected wipes of the index children's faces and hands, and they used the QFAT color scale to generate the quantitative ratings of facial and hand cleanliness. In addition to those enumerator ratings, field supervisors also simultaneously yet independently use the conventional qualitative metrics to generate data on facial and hand cleanliness from a validation sample of approximately 10% of households per study cluster. That allowed us to assess inter-rater reliability between non-blinded raters who were collecting the data in the field. Because we were interested in understanding whether ratings generated by individuals who were not blinded to the conditions of the household and the child were different from individuals who were blinded to those conditions, we had a master blinded rater use the QFAT methodology to rate facial and hand wipes in an off-site setting. So this was at a regional office. We also had 2 additional raters who were blinded to the conditions of the household and child rate a subset of those wipes to examine inter-rater reliability amongst blinded raters. And finally, Jed Snyder, a study team member, had the brilliant idea of using densitometry to generate computer simulated rating scores of a subset of those wipes that were assessed by the blinded raters. And I'll talk in a little bit more detail about densitometry in a minute. For our analyses, we generated descriptive statistics on conventional and QFAT cleanliness data. For the conventional qualitative metrics, we assess prevalence of individual signs of clean face and clean hands, while also assessing a composite indicator of clean face or clean hands. For the QFAT rating scores, we assess the distribution of scores across an 11-point QFAT scale. And because kappa statistics are often criticized, we use Gwet's agreement coefficient to generate chance-corrected agreement coefficients that adjust for the number of rating categories and the frequency with which they are used by raters. We also use quadratic weights to assess partial agreement between in the QFAT rating scores, and we use probabilistic benchmarking and the Landis and Koch benchmarking scale to interpret our inter-rater reliability results. As previously mentioned, we used densitometry to generate computer simulated rating scores so that we could compare those scores to human generated rating scores. For those of you who might not be as familiar with densitometry, it's a method that is commonly used in bench lab science to assess optical density. And we actually adapted an open access ImageJ protocol for the purposes of our study. And we normalized lighting between images by the use of a clean wipe, which was used as a negative control for calibration. Then the wipes were scanned for the darkest square ½ inch within the wipe. And this was a similar approach that the human raters used when they were in the field, rating the wipes. And then through the use of densitometry, histogram values of the QFAT color scale were compared to histogram values of the wipe images using the 5th percentile of the sampling frame. So this kind of simulated the scoring of that darkest area of the wipe that mirrored the human rater protocol. And here's just an illustrative sample of the wipes that we collected. And as you can see, the density of the color and the cleanliness of children's faces varied across our sample. For my results, in the interest of time, I'll just be focusing my discussion today on results related to the inter-rater reliability of the QFAT metric. So this slide here demonstrates that for facial and hand cleanliness, enumerators and master blinded rater had very similar rating scores that were highly reliable. And so you can see that if you look at this third column, IRR estimate, the inter-rater reliability coefficients are demonstrated here. And these range from 0.9 for facial cleanliness to 0.92 for hand cleanliness. Where an IRR estimate of 1.0 would reflect perfect agreement. So we can see these are quite high. In this next slide, we see that the 3 blinded raters also had similar rating scores and high inter-rater reliability. If you look at the 4th column here, you'll see those coefficients. And they range from 0.95 for hand cleanliness measures to 0.96 for face cleanliness measures. And the inter-rater reliability of the computer simulated and blinded human generated facial cleanliness rating scores range slightly by rater. But if you look at this 5th column here, you can see that they range from 0.96 to 0.98. And these were consistently high across all blinded raters. Finally, we take a look at hand cleanliness, the inter-rater reliability of computer simulated and blinded human generated hand cleanliness rating scores. And these ranged from 0.96 to 0.97 for the reliability, inter-rater reliability, which was also quite high. So in summary, our research group developed a novel cleanliness metric that allows for quantitative measurement of facial and hand cleanliness. The data generated by the QFAT methodology actually produced data that are finer in granularity than conventional qualitative cleanliness data. And having these more granular data could potentially facilitate better monitoring and evaluation of the uptake of personal hygiene interventions, and that are not typically afforded by coarser conventional qualitative cleanliness metrics. So in other words, these proxy indicators of personal hygiene could improve upon the quality of data available for conducting program evaluations and assessing intervention effectiveness. With regard to next steps, prior to COVID-19, we were in the process of launching a multi-country study to assess the reliability of the QFAT methodology in context within and outside of Ethiopia. We were examining the validity of the data generated by the methodology. So for this initial study that I just presented, we were focused on looking at inter-rater reliability. It was outside of the scope of our study to actually also examine validity of those measures, but we are in the process of launching a study to do that, where we will look to see that this methodology ensures that measures are indeed valid indicators of recent cleansing practices, which some of the conventional qualitative metrics, particularly those related to facial cleanliness, actually in studies have shown to not be valid indicators of recent practices. So we'll be investigating that a bit more. And we'll also be exploring the utility of different types of hygiene measures and investigating whether cleanliness, as measured by the QFAT methodology, reflects risk factors for diseases such as trachoma. And that's it. I'd just like to acknowledge and make note of the larger team of individuals involved in this research, as well as our funding agencies. And so I'll turn it back over to you, Maryann.
Maryann, thank you so much for that really fascinating insight into this work that you have undertaken. Clearly a hugely collaborative effort, lots of major partners involved there, and we're really excited to watch this space basically, and this tool has a lot of few diseases outside of that, and particularly at a time where the WASH sector and the NTD sector are looking at perhaps harmonizing some of the indicators that they work with. Something like this that clearly is over both fields will prove extremely useful. So thank you so much for this fascinating presentation, Maryann, and we can't wait to hear about the next steps. We had a question for you from a member of the audience, from Ugoi Mutombo, and this perhaps is a really great question because it draws a bit on your experience, not only at the Paterson University as well as London School of Hygiene and Tropical Medicine, where you were looking a lot at the socio-structural factors that kind of underpin health choices and health behaviors, and also really trying to look at ways to improve the adoption of health practices. And Goy Mutombo is asking, do you have any cost-effective solutions for developing countries who are considering behavioral changes? It's quite a broad question.
Well, I think it's a wonderful question. It's a great question. It's a challenging one, though. And I think as I've worked with different organizations and agencies and different teams in the field, I think what I've seen, just drawing on my own personal experiences, as being really important for thinking about cost effectiveness is actually thinking about interventions that will be locally and contextually appropriate. And while some might challenge that, actually, that those types of interventions or programs might be more costly, I think if we actually look at the effectiveness aspect of that, we've seen that some studies that have focused on infrastructure and coverage have really not been able to demonstrate health impacts. And so I think that's where we really need to kind of break down this black box that kind of falls along causal change from introducing infrastructure or a software, an idea, behavior change, all the way down to the health outcomes. I think we really need to unpack some of the behavioral factors that are driving those things. And I think in order to do that, you're going to need to think about, you could think about an approach that is contextually appropriate. And I think you need to, there are no silver bullets here. I think that's what's really important to kind of to think about and consider, because when we do try to scale things that are kind of a one-size-fits-all approach, we tend to get things that actually don't necessarily demonstrate impact. And that's not to say that you can't scale something. I think you can scale an approach, but it needs to be contextualized or adapted to the local context.
Absolutely, and that's very interesting. And just kind of as an aside, that's something that here at ISNTD we were keen to explore a little bit. We've actually launched a joint venture with actors. It's called Acting for Health, and it's precisely about kind of involving communities and using theater-based skills to hear a different side of the story, and so that is quite cost-effective. It's in the hands of communities, and it's been very exciting and interesting, particularly in the context of something like persistent schistosomiasis, to understand behaviors a little bit better. So thank you very much for that. So Maryann, thank you. I think you've kind of provided a very natural transition to our next speaker. Miryam, I see you've come back. Did you want to add something to that?
Yes, it was just a very informative.
Sorry, Lizette.
And I just want to congratulate you on developing this tool, this instrument that will be useful all over the world.
Thank you.
Super. And Lizette, so Lizette Burgers, you're Senior WASH Advisor with UNICEF. So clearly you've got a huge amount of in-field experience. And so perhaps, bringing together everything we've heard about the history and the evolution of hand washing, as well as quantifying its impact in the field, maybe you could tell us a little bit more about how an organization like UNICEF, with all your numerous programs across the world, applies hand washing, and particularly I think it would be interesting to hear in the context of COVID-19 as a very clear example of how you go about and do these things. So I'll hand over to you, Lizette, and thank you very much for joining us.
Great, thank you so much. And just as background, I'm a sanitary engineer by background, and then ended up in the slums in the 80s in Peru and learned a little bit the hard way, I think, that it's not about facilities alone. And it's just a couple of years ago, a new Masters of Public Health at the London School of Hygiene and Tropical Medicine, because the evidence base is important and we need to know where we're heading with our programs. And so, but then from the detailed kind of studies and that require intense programming to this COVID outbreak, COVID-19, this pandemic, I think we're all now familiar with it. The scale is as never before. I just checked the figures this morning, and it was now about 2.9 million confirmed cases with over nearly 200,000 deaths, and with the interesting fact that there is 1.3 million confirmed cases in Europe and 1.1 million rounding off in the US, and the other regions are far less. I mean, the Mediterranean with 170,000 cases, 144,000 in Western Pacific, and Southeast Asia still very, very low. Africa, 21,000. So they are still later in the curve, and we're all following it day by day. Now, coming to the behavioral question, maybe that was raised just before, we say, okay, what makes a hygiene intervention effective? We talk about hand washing as one of the key, hand washing with soap as one, or sanitizer as one of the key interventions. We know that we need to have knowledge, we need to have motivation, but we also need to have the capability. So the availability of water, hand washing infrastructure, hygiene supplies, time and decision-making powers are all as important. So let me just give a few figures. When we look at the figures of the joint monitoring program, which uses the availability or the presence of a hand washing facility as a proxy indicator, because it's so difficult to, or very costly to get national data on hand washing behavior. We see that 4 in 10 households do not have soap and water on the premises. So that is, we are going worldwide with a message, but 4 out of 10 do not have access to 2 of the essential ingredients. 5 in 10 schools do not have soap and water available to students, and 4 in 10 healthcare facilities do not have soap and water or hand sanitizer at points of care. So that makes that about 3 billion people are without a hand washing station at home, and 900 million school-age children without a hand washing facility in their school. Looking at the pandemic, I mean, schools were closed, kids are going back to school, we're expecting, so what is then the action that we're taking to make sure that that message to stop the transmission and to protect yourself and your others can be put in place? And that is also very important if we consider that there might be a second wave coming up. We all know that the biggest killer of the Spanish flu was in the second wave when it came back the year after. So a very important figure. Now also the inequalities are huge between urban, rural, rich and poor. Here an example from Pakistan, where you can see on the left a vertical, the 17% at national level, 17% of the poorest having access to basic hand wash facilities, and 94 in the richest. But if you then go to the urban area, you see that a little bit more than half of the population have access to facilities. In the rural areas, of the poorest areas, compared to nearly, it's 96% of the richest people in Pakistan have access to hand washing facilities. And the rural areas, the differences are even more striking. So in Central and South Asia, about 22% of the people in urban areas, and then I speak about 153 million people, lack access to hand washing facilities. Nearly 50% of the population in urban Bangladesh, talking here about 29 million people, 20% of the urban Indians, 91 million people. So we're talking about huge figures that make a certain behavior much more challenging than it sounds. Here an example from South Africa. The striking difference between rich and poor is heartbreaking. 4% of the poorest at national level have access to facilities, hand washing facilities, and I mean then hand washing facilities, water and soap, and 80% in the richest quintile, and in the urban areas, that's a little bit reflecting the same. And in rural areas, it's very poor overall. Less than one, a little bit about around 1/4 has access. So in sub-Saharan Africa, 63% of the population in urban areas, and here we talk about 258 million people, lack access to hand washing. 47% of South Africans And what I said, the richest urban dwellers nearly 12 times more likely to have access to a hand washing facility with water and soap. So those are the striking figures. It tells a story, and I'm just going here. I mean, we know that hand washing is very important. We know that it has been a little bit neglected over the years, although there are programs, and I'll come back to that briefly. But if this is the pyramid from CDC that we found on the website that looks at the pyramid of most effective towards least effective measures to an infection prevention. And then if you look at the personal protective equipment in measuring in effectiveness of stopping the transmission is lower at the rank than the hand washing, the administrative controls where you say we have hand hygiene. The top is the social distancing, and luckily that's being applied in many countries and all over the place. But we are a little bit worried sometimes about the positioning of the hand washing message. If you look at the discussions that we're having about the masks, about the rumors, there's so much noise outside that it's very important to remain focused on the agenda. And that's why there are different collaborations happening. There is a new hygiene hub. The London School of Hygiene and Tropical Medicine has created with different partners a hygiene hub to make sure that expertise from the epidemiological, technical, and behavioral side can be called in, but also that there can be easily tapping in of expertise from the people at the country level, because that's where all the action's happening. So just a few words about the response to COVID-19. Of course, it is all embedded in the WHO response, that is the Strategic Preparedness and Response Plan, which is centered around 8 pillars. I won't go into that. I assume that most of you are familiar with that, but I just want to highlight that the hand washing activity are fitting in 2 of these pillars. There's one pillar that's called risk communication and community engagement. It deals with the messaging, with the hygiene, with all the rumors and the information that people need. And there's another pillar that is looking at infection prevention and control, which was originally focusing particularly on healthcare centers, which of course is a very important part of the response, but is also with different partners in the WHO, we are really focusing also on the schools, on the public places, on the communities. And that is very important because there is no specific, what we call a water and sanitation element in this COVID response in the pillars, and so you need to look at the response to fit the response into the existing templates and formats, and that took a little bit of negotiation and still remains a little bit of negotiation. And I'm just saying that because one of the key elements in the response is working together and the speed of response. And so collaboration and building on what is there is so important for each of us. So for UNICEF, we did, of course, very quickly use our network and our collaboration with governments to get country response plans. This is already a little bit outdated. I think we have by now all the response plans in place. And we were building on our country WASH programming. So for example, in 2019, we had 88 countries where we had a WASH program. So you see now that with the over 140 countries with response plans and a WASH component in it, you see that this is expanding the number of countries that we're working in. So that means we may push or we may look at impacts and how to support, but that means that, of course, that UNICEF is not going to do that alone in most of the countries, if not all. Apart from collaborating with the governments, it's partnering with every agency and player that can play a role in that context. So, but in 2019, we had 53 countries that supported already community-based hand washing programs, and we had in about 60, nearly 70 countries. We had media-based national hand washing campaigns. So that is, we were building quickly on the response that we were having. As COVID-19 really required a truly global response. We're also dealing, of course, with a lot of countries that have a double burden, and the countries with a humanitarian crisis. In these situations, there is a risk that the host governments and humanitarian communities are not able to immediately deliver life-saving services. And also people in these crises are likely to be more vulnerable as their living conditions already involve poor wash and limited social safeguards. So those countries are getting a priority. So speed is important, and that's where we work in all these countries immediately. We have had webinars with all the regions, with over hundreds every time of participants in that. And last point in the response is, of course, the disruption to markets and supply chains. This is an unprecedented crisis where we're used as UNICEF to work in emergencies. Many agencies, probably many of you are used to work in emergencies. But this is one where even supplies cannot come into the countries, where if we're not very fast and negotiate with a government, water and sanitation people are not considered as essential people because it's a health response. And so, and where markets and supply chains are heavily disrupted, and we have seen that in the surge of prices that we see. So a few words on how we then position in this COVID-19 response the hygiene programs. The first is then the hand washing to prevent human transmission. There we work on the messages tailored to the country context with different channels. The access to the infrastructure, particularly in vulnerable communities, the emergency, but also the urban slums, and of course the national coordination building on the existing programs are essential. Maybe a few quick examples. In China, the essential information reached about 44 million people on one of the biggest social media platforms, Sina Weibo. And when schools started to reopen, UNICEF started to work on the messaging and to help people, teachers and students return to schools. And that's now also for all the other countries happening. In Pakistan, there were already strong communication networks in WASH, and a total of 811,000 people were reached with COVID-19 hygiene promotion messages. And the social media platform reached about 7.7 million people with messages. Different staffs were trained. In Rohingya, in Bangladesh, in the crisis area, the radio was one of the major channels, because face-to-face traditional measures are much more difficult, and also the size. But in Rohingya, when we started 2 or 3 years ago with the hygiene promotion, it became obvious that most of the Rohingya people were not able to read, or that there was very little capacity to read written messages. So there, one of the message areas is particularly the channels is particularly radio. So some of the previous Maryanns, I have to check which Maryann in pronunciation, but said already context is so important, and we all know that that's true. Just one or two quick examples more. In Burundi, we had an innovative partnership with one of the largest soap factories. The 12 million people, only 1/3 was washing hands with soap. And so they had a program already selling 12 million bars of soap per month at a subsidized price. Always difficult to say, okay, are we killing the market? What are we doing right or not? In this case, it was decided to go for a subsidized price, and by eliminating the VAT and an extra contribution. And now the soap company is switching its existing production line to basic soap. And so get quicker access. This just as an example of thinking other than only the messaging, but also access of soap. In South Africa, there is, together with different UN organizations, funding to utilities for setting up temporary water points and hand washing facilities in townships and informal settlements. Working together on hotspot mapping. So just as a few examples. So to really close the way forward, I mean, what I said already is collaboration, cooperation, really support to the governments, looking at the existing technical hubs and that are there to provide support. There has never been such an willingness to work together, to work with speed and to be as practical as possible. WHO is at the moment working with us and with several others on, it issued already a recommendation for hand hygiene in public places. Now, to give that space, when we think about the 3 billion people that do not have access, and especially in the most vulnerable areas, that requires much more than a messaging approach. It needs a systems approach to hygiene programming. I'm thinking about the previous speaker also. Measuring will be very important. So what are the indicators? How are we going to move to measure success? As I said, focus on the most vulnerable populations, the innovations in hand hygiene hardware. I was just too late to include the IDS companion on hand washing. If people are interested, I can share the link. IDS in Sussex just did a companion of low-cost hand washing facilities. It's a living document. And it's great help. We are working with our supply division to bring together some guidance on procurement and local devices that can be made together, so that there is some technical support to countries. And then, of course, the last point, the hygiene promotion programs with limited human contact, so not the face-to-face messaging and encouragement, but the embedding of the messages in programs that are different in shape. So I was just recently talking, I think it was with Hans from Ranas recently, that they said, okay, even in communities, we think about with a megaphone to have one person in a community, but from a distance. So there are different ways and different initiatives that people are thinking of to make sure that every person can be reached for hand washing. There's a lot of documents out. I wish I had been included here, the IDS document, the link to the hygiene hub of London School. And I understand that our colleagues have already shared the WASH bulletins. Several of these tools and resources are available, and we, of course, through the different platforms, will continue to share any existing documentation that is available. Just to highlight, on the left side was the first technical brief, the WASH technical brief, that tried to compile the existing evidence related to the transmission of COVID when it comes down to water, to waste, wastewater, and so that might be a useful document. As said, this is a new outbreak, a new pandemic as we have never experienced before. So all these documents probably will remain some living documents, because we expect an increase in interest, but also an increase in learning, because everybody of us is learning every day. So we hope that in your programs, many of you are in already some related programs. Yeah, let's work together and learn together. Thank you.
Thank you very much, Lizette, for that. Are you looking for partners to come on board and perhaps to join you in whichever capacity they can? Is this kind of an ongoing discussion you would like to broaden as the pandemic develops? Yeah, that's great. We are currently looking at how we were going to work on this request or this recommendation to have hand washing in public places. And that will be huge. As I try to outline, it's not only the messaging and reaching the people, but it's really to make sure that all these ingredients, water, soap, a facility close by, and the decision power to use the facility is there, so that there is no exclusion, and that everybody can practice that what is needed to survive and thrive. That makes sense. And I had a question for you, actually, which perhaps we could expand to the other panelists, and also kind of brings together a few of the questions that have been raised and comments on the chat. But for yourselves, as you know, with all your years of experience with this kind of messaging, and it's been advocacy all along the way, as you say, not just in terms of messaging, but also making sure the infrastructure and the tools are in place. And suddenly, within weeks, everyone's washing their hands. I mean, I think the standard statistic is pretty dire. Globally, 19% of people wash their hands after using the toilets, or even in healthcare facilities. It is estimated that up to about half, healthcare professionals themselves are only washing hands in half the cases when they should. And I am not blaming them. I'm sure there are structural problems there as well. But, for professionals that have worked in this field all this time, what do you make of the rapid and incredible change in behavior? And also, how do you feel you could harness this momentum to apply more pressure on the powers that be, on governments, on the development agenda, to make sure that this remains sustained? Wow, that's a very nice question. I don't know if the others want to respond earlier, but I think it is, for myself, it's tremendous. I mean, when Global Hand Washing Day was introduced, it was considered, I mean, we knew that hand washing was a very effective way of stopping transmission. The Lancet series showed that. But it's also, it's a practice that you need to do every day and every moment. And if you compare that with vaccines, that's much more difficult, because a vaccine, even if you have a repetition of the vaccination, you need 2 or 3. You see that there is a drop in uptake towards the second and the third. Mm-hmm. And so here we are having behaviors that we are asking people to practice every day, while also the access is not there. So it's a public health intervention. And I'm coming back to Semmelweis. I mean, it was neglected when he was showing results, and he ended insane. It has been neglected. So we have really seen that
with the antibiotics and the vaccines, we have made big gains. But we also need to remember that in Europe and probably also part of the US, the decline in infant mortality went down far before the vaccines and the antibiotics were discovered. So hand hygiene is very important, but we came with other ways of treating. We got it very much down, and so it has been neglected to a certain extent. And so this is a call. Some people say it's a call of nature. Some people say it's a call of God, but it's probably a call of nature, that if we are neglecting the public health issues, it's coming back. And so we're building on that. Yeah, so with that, I think I think we have a momentum here. It is now, and that's why I put in my last slide, it's a systems approach. We need to embed it. It's unacceptable that health centers do not have access to safe water, not only for drinking, but also for its hygiene. That schools are now, there was one in one of the countries, I know it was in one of the states here, they're now talking, no, in Hamburg, in Germany, and they are doing so well. They're now, there's a big uproar because they're now talking about, we need to make sure that we have soap in the schools. And people say, huh? Now? I mean, soap in the schools, shouldn't that have been every time? So there's a lot of uptake. It now touches all of us. But last point, there is a change in the messaging. So it needs to be every day, but we always said it needs to be hand washing because of stopping the transmission after defecation and the fecal oral. I mean, I've been one of the persons. This COVID shows that we also, I mean, it's deformative, I think you call it, if people have, the transmission is through surfaces also, and by touching. So now we need to wash hands when we come out from outside, which is a very important one, and not touch our faces. So there are other messages coming in, and it's not only the fecal oral. And as a sanitary engineer, I'm also now looking at how to change that behavior. Last point, we also, I mean, while random control RCTs trials are important, it can also be a little bit of a tricky. One of our biggest supporters, Bill and Melinda Gates Foundation, and in the sector, they decided a couple of years ago not to invest in hand hygiene because the evidence was not there. So maybe it's a call for better measurement, but it's also because it's so complex, context specific, it's not perfect. And so if there's no evidence, there's no investment, and we need to be a little bit careful and relook also at that. Sorry, I spoke too long. Yeah.
No, not at all. And so cue Maryann with the data and the quantitative side, so that it's great to see that coming together and you making the case for that. Yes, Miryam? Oh, I think your audio is muted, Miryam.
So Lizette, your presentation just shows how hard the work will be to just get the basic necessities to a great portion of the population. And I also discovered that when I was doing research for the handbook. My philosophy is not to make everybody germophobic, but I call it germ aware. Germ awareness is, I think, a big part of it. And right now we're in the pandemic of germ awareness, and I think that I'm hopeful that some of that will stay with us when we get beyond this particular crisis. But it starts with the children and the babies. But by the time they get to middle school, they already forgot everything, and they go to the bathroom and don't wash their hands. A lot of these youngsters. So we have to continue that education through young adulthood and continue that message of germ awareness. And again, as you said, you go out in public, you come home, you better wash your hands. We see the threat now as a real threat. But beyond this crisis, how to sustain that awareness It's going to take a lot of different resources and an organized approach to continue this message. This is the message that you are all out there in the field promoting, and I congratulate all of this particular panel of very prominent people who are working in the area, and all the public health and healthcare workers who are doing an amazing job. And I hope that we can continue to promote this message.
And maybe one more point, just building off of what was just said. In terms of thinking about behavior and changing behavior, disruptive moments, things that interrupt our routines, are an opportunity to incorporate new behavior. And so we really should be thinking about leveraging what's happening now in the current situation to build momentum and moving forward. One thing that was really interesting to me, I had a colleague a couple of years ago when I was talking about collective action and different types of things that we promote. I mentioned hygiene, and this person kind of challenged me a little bit and said, do you think a personal hygiene practice such as hand washing is actually something that relates to collective action? And I think in situations such as this, absolutely. So a lot of people are talking about collective action around social distancing, that we're all in this together, that we can make a difference, that if we socially distance, we can, flatten the curve. But there's also an opportunity to kind of leverage what's happening to build momentum around identifying negative externalities of hand washing. And so basically what that means is that my behavior, what I do personally, not only influences me and my health, but the health of those around me. So my children and my community. And I think this, the COVID-19 pandemic really gives us an opportunity to kind of reframe that issue of what is personal hygiene in terms of collective action, and how we can kind of re-message, reframe what's happening, align our interventions to address these specific types of issues that extend just beyond sanitation or safe drinking water, that go out into these personal hygiene practices as well.
That's an excellent point. And as you say, definitely when disruption occurs, then this is a great opportunity to kind of reframe the whole discussion. So hopefully we will bear that in mind. There's been a few offers of resources on the chat. I just thought I'd flag Erin Palomares from the Global Handwashing Partnership in DC. Had to go, however, just wanted to flag their resource hub, which serves as a central platform for handwashing and COVID-19 resources. That's found on the chat. And also we've got here, someone's phone's ringing. Ngoy Mutombo saying, we did a successful behavior change program in India through schools, and we have found that the children made the changes in their household. So that's very promising. And Ngoy is also interested in a partnership for a project, as well as sourcing soap bars and messaging for 1 to 3 year olds. So Ngoy, if you want to perhaps send your email address, or we can share that and ensure that people are able to get in touch with you to partner. So I think definitely this shows on many levels the willingness of the hand washing, the wash, and the public health community to really act quickly, putting together resources in response to this COVID-19 disruption, and therefore opportunity in a sense. There were a couple more questions on the chat. I'm conscious that we've been running for nearly an hour and 40 minutes, but it's been really a gripping session. So certainly we're quite happy to carry on. Maryann, the questions were, some of them were quite specifically looking at the work you've done on the metric tools. So perhaps I could put you in touch with those people, or we could take one of the questions. For example, Armel Forer was asking, I look forward to seeing the QFAT in action, i.e. how it reflects the risk for diseases and is used for intervention effectiveness assessments. And Helena Uliartha from the Ministry of Health Indonesia builds on from that, saying, do you find any difficulty or limitation in your approach? And linked to that, Armel was asking, do you make any agreement assessments between non-blinded raters and the tutor?
I think these are all very good questions, and I'm happy to answer those via email. I'm also happy to take some of them now. I think with regard to limitation, right now there is a need to procure wipes and to get them out into the field. The work that we did in this initial study, we also used baggies to kind of protect those wipes. But in subsequent studies that we're doing, we're looking at eliminating or reducing the need for that. And I think what we're really interested in doing is moving this away from even a need to kind of procure the wipes themselves. This is kind of a proof of concept, and we have a larger vision for how we can move that forward. But again, I think all of these steps are dependent on the next question, which is really ensuring that this metric or the measures generated by the methodology generate valid measures of recent cleansing. And I think that's the main challenge, that we need to kind of ensure that this is a valid metric. Others that have been done or have been promoted don't necessarily reflect recent cleansing practices. So that's something to consider. And I think I also saw in the chat box, there were some questions about ash and whatnot. And so that's certainly something that we would need to consider for those who are cleansing with ash. You know, the quote cleanliness as picked up by this metric, there would be a bit of challenge on that. We do have some ideas for how we could work around that. But again, I think this would, before we promote anything, I think we really need to kind of make sure that these other measurement attributes are examined so that we know where things stand with regard to those aspects of things.
Thank you, Maryann. And just picking up on your point about the chat, as you mentioned, there were a few questions about what happens when you don't have access to soap. So are other methods, such as using ash or sand, are they equally effective? And Miryam, I think you answered saying that, well, you go into a little bit more detail about that in your book, but overall, one thing to be very cautious about is the quality of the sand and the ash to ensure you're introducing more pathogens.
Exactly,
So
yes.
a bit of a complex response there. And then finally, perhaps to kind of conclude, summarizing a few of the questions on the chat, a lot of people have been wondering, and of course it's a rapidly evolving situation, but what accounts for some of the disparities in the incidence of COVID, for example, between, you know, why are the case rates at the moment very low in the African region? And also someone was giving an example from DRC where there seem to be more cases in some of the wealthier neighborhoods of the capital rather than the poorer suburbs. So this is, you know, not directly a hand washing question, but perhaps from your experience, if you have any insights. It is a theme that kind of came up a few times during the chat. I don't know if who would like to go first on that one.
Yeah, maybe a quick one. I mean, we need to keep in mind that the outbreaks in Africa, in particular, where the cases are still very low, has been much lower and later. We see a similar effect with Latin America. It just came later, and so measures were earlier, but also many flights were stopped. So the transmission. I mean, the influx was more limited, and they had more time to prepare. But having said that, we're looking with very, very careful eyes because we have every week a call with our regional advisors. 2 or 3 weeks ago, there were a couple of countries in Western Africa that had cases. And then in the call last week, all except one country, but they felt it was more of a matter that they were not measuring, didn't have the systems in place to measure, and all the countries were having cases. And so it can go, so because it goes exponentially, it can go up very, very fast. Why the rich and the richer areas? I mean, it probably depends also on what programs, or maybe arrogance, I don't know. I think it's a little bit early to say why it moves. Some people are talking about immunity, but I think that there is no evidence base for that yet to say. So I maybe to the experts of the epidemiologists.
I think it's also very early to complete this type of analysis. But one thing I can say about the New York experience, and I live in the New York metropolitan area, is that at the beginning we were told, do not wear masks. You don't have to wear masks. And that is very in concert with Americans anyway. We're not used to that. It's just not part of the culture to cover the face and to wear masks. So people went along with that. At the beginning, they were trying to preserve the masks for healthcare workers, which is why I believe the message was very clearly stating regular people who are not sick don't have to wear masks. I think that would have made a difference, but that's my opinion. That did put us several weeks behind in terms of controlling the transmission, I believe. But certainly the message is out now. And I think if we can use our experience to communicate with parts of the world that are just at the very beginning of the curve, maybe they can flatten it sooner by taking some of those actions right away and really not ignoring it and taking it very seriously. So I'm hopeful that the parts of the world where it hasn't become as critical as the New York area would please learn from the experience that we're having here.
One other thing I would add on to that, and this is maybe a bit of a sensitive subject, so I'll tread lightly here, but I'm always interested in denominator data. So how many people are being tested? And I think that some of this wealth disparity and positive tests amongst wealthier could potentially be an artifact of those individuals actually seeking care in a health facility that actually has the tests and are conducting those. And so I think it's really important to use data to inform decisions, but also to be cautious about interpreting those data. And I think it's really important to be considering what proportion of your population has been tested and is that sample size representative of the population. So.
Absolutely, that is you want to make sure you're comparing like for like, and that's really crucial in these cases. I think it's very telling that we've nearly gone 1 hour over our sort of expected time. This has been a truly fascinating session. We're so indebted to you as our speakers and really extremely grateful. You've managed to take us in a very seamless way all through the history of hand washing and then what this means all the way to a very concrete and real current day pandemic, as well as looking at quantitative tools and all the way to behavior change issues. So I think we're coming up to the end of our allocated time, but I just wanted to thank you again once very, very much for this incredibly insightful journey the three of you have taken us through, Miryam, Maryann, and Lizette. It's really been a great pleasure to have you discussing hand washing today. I think one thing we will all take from this is that we must seize the moment and make sure that the soap dispensers in schools remain filled, metaphorically and as well very concretely. And we look forward to keeping in touch with you, hearing more from you, and seeing the next steps in all your work and all your fields. I'd like to also say a very big thank you to our audience. Everyone's being very grateful on the chat. Hamid Habib Jemli saying thank you for the whole group. Arowana Fros, thank you for the response, Dr. Wahrman, and thank Ngoy Mutumbo, thanks to all three presenters. Thank you for great presentations from Radisha Ivanieshko. So all round, it's been a real pleasure getting together today. And we hope that everyone will keep safe and keep in mind all the great findings from today. I'll just like to remind, if anyone was wondering, the recording will be available very shortly after the webinar. So if you feel you've missed anything or you'd like to hear a little bit more, then please do head over, jump to our YouTube channel. And on that note, I'd like to thank you again once very much and wish you all the best. And hope to see you very soon again.
It's been my honor and pleasure, and stay safe and well, everybody.
Absolutely.
Yes. Thank you, Maryann. Stay well, everyone.
Yep.
Thanks to all the Maryanns and all the
Yeah.
Thank you.
All right.
See you.
Thank you very much, everybody, and keep safe.
Yeah,
Bye.
you too. Bye.
Take
Bye.
care. Bye.